Section 1. Fluids and Nutrition.
Okay, you absolutely have to have the 4-2-1 rule locked down for calculating fluid replacement. Since total body water in kids is about 75% compared to an adult's 60%, precision here is literally everything. It goes like this: 4 mils per kilo for the first 10 kilos, 2 mils for the next 10, and 1 mil for every kilo over 20. Your ultimate goal? Titrate that to maintain a urine output right between 1 and 2 mil per kilo per hour. Also keep in mind their total blood volume is roughly 80 mils per kilo, which means any fluid boluses you give should be right around 10 to 20 mils per kilo.
Now, looking at parental nutrition, these starting values and daily titration goals are crucial for managing neonatal GI anomalies. Notice how heavy we go on carbohydrates. They actually provide 60% of the daily calories, and we titrate that up to 14 milligrams per kilo per minute. But here is the classic exam trap. Insulin is not routine in pediatric TPN. Because their cells are totally naive to exogenous insulin, they are incredibly sensitive to it, meaning you risk causing profound hypoglycemia if you aren't careful.
Section 2. Tracheoesophageal malformations and CDH. Take a look at this classic radiographic presentation of pure esophageal atresia. You can clearly see that coiled orogastric tube ending abruptly right in the upper chest. But the real dead giveaway for pure EA is actually lower down. Look at the abdomen. It's completely gasless. That tells us there's no distal tracheoesophageal fistula connecting the respiratory and GI tracts. Practically speaking, pure EA usually means a long gap defect. So you'll start with a gastrotomy first and tackle the delayed reconstruction later. So if you spot that esophageal atresia or a TEF, your brain needs to immediately scream vectoral. Up to 2/3 of these patients have associated defects. You've got to aggressively work them up for vertebral, anal rectal, cardiac, tracheal, esophageal, renal, and limb anomalies. If you get tunnel vision on just the esophagus, you could easily miss a fatal cardiac or renal issue.
Moving on to the diaphragm, check out this stunning X-ray showing a classic left-sided bacchitalic hernia. What happened here is the diaphragm failed to finish developing around 8 weeks of gestation, so all those abdominal contents just herniated straight up into the chest cavity. Now those bowel loops visually dominate the image for sure, but remember, the bowel itself isn't what kills the infant. The true killers are the severe pulmonary hypoplasia and pulmonary hypertension caused by that compression. Because of that, the immediate management of CDH heavily prioritizes cardiopulmonary stabilization. Do not rush these kids to the OR. You want to immediately intubate, decompress the stomach so the lungs have room to expand, and use permissive hypercapnia. If things get really severe, we bring in ECMO, but the criteria are strict. The neonate has to be over 2 kilograms, greater than 34 weeks gestation, and have a reversible process. You only do the operative repair after they are fully stabilized.
Section 3. Abdominal wall defects. Differentiating these two is a guaranteed exam topic. An omphalocele is basically a failure of the midgut to return to the abdomen. It leaves the bowel trapped in a peritoneal sac right at the umbilical ring. The massive clinical hook to remember? 50% of these kids have major genetic or cardiac anomalies. Gastroschisis, on the other hand, is likely from a vascular insult. There's exposed bowel with zero sac. It's reliably located to the right of the umbilical cord, and thankfully, it comes with a much, much lower rate of associated anomalies. Section 4. Necrotizing enterocolitis, or NEC. Zoom in on the right upper quadrant here. Do you see that weird, bubbly, almost cystic appearance right inside the bowel wall? That is pneumatosis intestinalis. It's the absolute hallmark radiographic sign of NEC ischemia. This disease is the most common neonatal GI emergency, and it usually hits premature infants in their first month of life. They'll typically present with feeding intolerance, bloody stools, and lethargy. Let's break down the management algorithm. About half of these patients actually resolve with expectant medical management. We're talking strict bowel rest, NG decompression, and broad-spectrum antibiotics. But you have to monitor them like a hawk with serial exams and x-rays. The absolute second you detect free air, which means the intestine is perforated, or if they severely deteriorate clinically, you pivot to surgery instantly. Depending on how stable they are, that means either a formal laparotomy with bowel resection or a quick bedside primary peritoneal drainage. Section 5. Intestinal anomalies. If you get an upper GI study showing a classic corkscrew duodenum, drop everything. It's a volvulus from malrotation, and it's a massive surgical emergency. You have to rush to perform the LAD procedure.
Step 1, you eviscerate and untwist the bowel counterclockwise. Think of it as turning back the hands of time. Then, you divide the lad bands, broaden out the mesenteric base, and critically, you always do an appendectomy. Why? Because you're leaving the cecum in a totally abnormal spot, and you want to completely avoid any future diagnostic confusion if they ever get appendicitis symptoms down the road. Now, for Hirschsprung disease, where we're missing those crucial ganglion cells in the myenteric and submucosal plexuses, you need to recognize 3 definitive pull-through operations. They all have the exact same goal: bring healthy, innervated bowel down to the anus. The Swenson procedure just removes the bad bowel entirely for direct perineal anastomosis. The Duhamel leaves the stump and pulls the good colon down behind it. And the Save dissects out the mucosa and pulls the healthy colon straight through that remaining muscular cuff. When it comes to anal rectal anomalies, your physical exam dictates everything. You have to think algorithmically. First, look for an anocutaneous fistula. If you see meconium at the perineum, boom, it's a low lesion. These are great because you can often fix them right away in the newborn period with a primary perineal anuloplasty, totally skipping a colostomy. High lesions, though, those demand a staged approach. You'll start with a split sigmoid colostomy to divert the stool, and then come back months later for the definitive anorectoplasty.
Section 6. Thoracic Pathology.
Let's talk about lung tissues that have an aberrant blood supply and no real bronchial communication. The absolute key to telling these two apart is their pleural covering. Intralobar sequestrations are trapped right inside the normal lung's pleura. This makes them extremely prone to infection, which means they mandate surgery. Extralobar sequestrations, however, have their own entirely separate pleural layer. That gives them a much lower infection risk, but beware, they carry a massive 40% association with other congenital defects like CDH.
Finally, I want you to burn this clinical trap into your memory regarding congenital lobar emphysema, or CLE. This causes a massive overdistension of a single lobe because the feeding bronchus collapses and acts like a one-way valve. On an X-ray, it looks exactly like a tension pneumothorax, but if you place a chest tube, it is absolutely detrimental. The real treatment is an emergent lobar resection. Keep a close eye on CPAMs and bronchogenic cysts as well. Both of those need to be surgically resected due to their high risks of infection and future malignancy.
Well, we've covered massive ground today, distilling a ton of complex physiology into these high-yield testable algorithms, which leaves us with one vital question to ponder. In a subspecialty where split-second anatomical recognition literally dictates life or death within hours of birth, how will you adapt your adult clinical mindset to master the rapid, high-stakes world of pediatric surgery?